Good morning, everyone. Welcome to our rounds for March. Today we have Jeff Gagne joining us from DSAB, so District of Parry Sound Social Services Administration Board is what that stands for. In this role, he provides operational leadership for Ontario Works and the Housing Stability Program, working with internal teams and community partners to support effective client-centered supports and services. Jeff has led the implementation of several key initiatives, including employment services transformation in Ontario Works and the housing loss prevention strategy and encampment response plan in the district. He also serves as the co-chair of the Health and Social Services Network. Welcome, Jeff. And just as a bit of housekeeping, if you have any questions, you're welcome to interrupt them during the session or put it in the chat or save it to the end. He's open to everything. Welcome, Jeff.
Thank you for having me. Much appreciated. So I will share my screen.
You may have to hit that setting again as we go in.
Yeah, no, I think we're good. I can see it. So,
Okay, perfect.
all right. So today, very grateful for the opportunity to speak with all of you. Just talk about health, social services in the system of care, and working together to improve outcomes. As Kathy said, my name is Jeff DeGagne. I'm the Director of Income Support and Stability with the DSAB, and I oversee the Ontario Works program as well as our Housing Stability program. This is just my disclosure, my affiliation, like I mentioned, I'm presenting today representing the DSAB, and I have no financial relationships with any other for-profit or not-for-profit organizations, and I've received no financial or in-kind support for this presentation. So the learning objectives of today give you a DSAB 101, a quick overview of DSAB services, and we'll focus in on Ontario Works and housing stability. We'll talk about the system of care and intersection points with the healthcare system and how barriers related to health impact life and housing stability. We'll take a look at the cost of homelessness. We'll look at evidence on the public system costs and how prevention and how housing-focused approaches can reduce high-cost service use. And then lastly, we'll take a look at what the local realities are. We'll talk about the DSAB's housing loss prevention strategy, what homelessness looks like in the district, and how our partnerships with healthcare partners have worked to prevent chronic homelessness. So why does this matter? The DSAB provides many supports and services that address social determinants of health, such as early childhood development, income security, employment, and housing and homelessness. Housing instability and extreme poverty, they're health risk factors and it affects an individual's overall safety, their overall health, nutrition, and access. And that could be access to services, supports, financial supports, a variety of different topics. With a coordinated system of care approach, this can improve outcomes, and it also works to reduce the demand for high-cost crisis services such as hospitals, correctional facilities, mental health facilities, and the like. So the first area is DSAB 101. What do we do? First is we are the administrator for social assistance, Ontario Works. We provide income support to stabilize shelter and basic needs. As well, our team provides life stabilization supports and service navigation where appropriate so that people can improve self-sustainability, whether through employment or through other supports that can hopefully lift them out of poverty. We provide housing stability and homelessness prevention services. housing loss prevention supports and coordinated pathways out of homelessness, and also housing focused response for those who are experiencing homelessness. We're also the service manager for housing programs and community housing. That means managing our rent geared to income wait list and our community housing program and stock. They also assess eligibility for rent supplement programs and other housing related programs in the district. We're also the service manager for childcare. We provide and support quality childcare throughout the district in a variety of ways. We directly operate childcare centers. We support external operators like the YMCA or Adventure Academy. We operate home childcare programs throughout the district, inclusion support services, and early on. Inclusion support and early on, they intersect a lot with uh, mental health. They'll intersect with hands, one kid's place, those types of areas, most definitely. And lastly, Esprit Family Resource Center is the program and the shelter that supports women and their families that have experienced gender-based and intimate partner violence. So jumping in, having a look at Ontario Works. As I mentioned, OW provides financial assistance for basic needs and shelter based on an eligibility criteria that is legislated through the province through the Ontario Works Act. Uh, it's deemed by the province as a short-term employment assistance program, but the goal is to provide referral coordination to life stabilization supports and services such as crisis and safety, as I mentioned, the shelter, it could be homelessness supports, those sorts of things, healthcare supports, medical needs, mental health and addiction supports, life skills and literary and basic skills. We work with education providers in the district to skill up individuals so that they can become employment ready and hopefully move on to sustainable employment at some point. And we also try and connect people to community supports such as housing, transportation supports, multicultural and legal supports. The current caseload in the District of Parry Sound is 603. That includes 932 beneficiaries. Our ODSP caseload, which is the provincially operated, but is for people with disabilities, that caseload sits at 1,511 with 1,984 beneficiaries. And for context as well, that 6.2% of the population of the District of Parry Sound is accessing some sort of social assistance program. And as well, for context, in terms of the barriers that our people face, a single person, which is makes up roughly 2/3 of our local caseload on OW, and mostly in the province as well, receives at a maximum of $733 a month. I referenced the recent infographic that the health unit sent out around food insecurity, challenges with affordability with housing costs, food costs. We're seeing it more and more, transportation costs with the recent events happening in the world. These are a significant strain for somebody on social assistance with that small amount of money on a monthly basis. So what are the barriers that our clients face? Um, Prior to employment services transformation, we were able to uh, assess this information from clients in a very impactful way. And what we saw uh, from the caseload was majority of individuals self-reported that physical health, mental health, and addiction issues were their biggest barrier to employment, and with many struggling to access care and access a family doctor. Shifting into housing stability, a focus on prevention. So housing loss prevention includes a variety of supports such as rental arrears and utility arrears where individuals are eligible. We work with landlords as well and try and provide mediation to prevent eviction. We utilize diversion and rapid resolution. Um, and I'll get into definitions a little bit too, but this is when individuals may be entering into homelessness or about to enter into homelessness, where when we intervene, so um, they don't move into chronic homelessness. Our goal is to make homelessness rare, brief, and non-reoccurring. We try and provide coordinated access to supports and services, referrals, and case management to help reduce fragmentation and repeat crisis. And we use clear definitions to support objective triaging and prioritization across sectors. A big focus of the DSAB, a big focus of my team at this time. So, like I said, I'm very I appreciate the opportunity to speak to you today because we're very much in wanting to give a common language that us and our partners can all speak in terms of what homelessness is and what homelessness looks like, and that we're all speaking with a common terminology. So this is from the Canadian Observatory on Homelessness. And again, more and more of the data, more and more communities putting a focus on preventing homelessness versus a crisis response, which is shelters, hospitals, jails, all of that stuff. Um, the results through prevention are proven to be much more successful. So I just wanted to share that, and that more and more communities across Canada are showing that prevention works. And again, you're going to hear this a couple of times throughout the presentation, but the goal is to make homelessness rare, brief, and non-recurring. I'm going to play a short little video for you, my bearded fellow here. This is Mr. Ian DeYoung. He is the president of Org Code Consulting. He is a true leader in homelessness response. He provides consultation to the Canadian Alliance for Ending Homelessness. He organizations all across the United States and Australia as well. Um, his organization Orcode, and I'll get into it, helped assisted us in developing our housing loss prevention strategy as well as our encampment response strategy. So I just wanted to play a short clip from him in terms of the importance of prevention in homelessness response.
Prevention is the part of the story we rarely tell, but it's the smartest play. Conflict mediation before families implode, that's smart. Supports that catch kids before they're tossed, smart. Turning foster care into a springboard instead of a cliff edge, smart. And let's talk money. Prevention is cheaper, way cheaper. But apparently we'd rather save pennies now and spend fortunes later. That's like refusing to buy smoke alarms because you don't want to waste money, then acting shocked when your house burns down. Prevention isn't just fiscally smart, it's morally obvious. Prevention.
So we'll jump into, and I'll show you guys some data in terms of prevention in the area, prevention in the district in terms of what that strategy is doing, and how we've been working to stem the tide of what we see in a lot of the larger urban centers throughout Ontario, throughout Canada, throughout North America, in terms of chronic homelessness, visible homelessness, that sort of stuff. So I talked about speaking the same language. What is homelessness? What are these things that he's talking about? So I want to just go quickly, give you a quick little overview in terms of the definitions of the work that we do. Again, I wanted to promote speaking the same language and starting from the same point. So homelessness is the situation where an individual or family is without stable, safe, permanent, and appropriate housing or the immediate ability to acquire it. This is very broad, and I think we know and we recognize throughout the district with the mutual people that we serve that we recognize there are a lot of people who may not be living in ideal situations that you and I would want for them. But in our context of the lens of homelessness, they're housed. Do we want better for them? Do they still receive support from our agency? Do they still receive support from the community and community partners? Yes, absolutely. It's just what bucket do we put them in terms of our data collection, all of that stuff. So an example I'll use as we were going through this and developing the strategy was a woman who is living in an apartment and she is trading sexual favors for rent. Shocking to all of us. We would not want that for our daughters. We would not that for our family members. But she feels that she's safe. She feels that she is housed. So we need to view it as that. Do we continue to provide supports? Yes. Do we continue to encourage her to look at something different? Yes. Homelessness is sleeping in a tent, sleeping on the street, sleeping rough, couch surfing, that sort of stuff. Encampments have been getting a lot of play as well. So again, I mentioned tents. So encampments are like little communities. So it's usually two or more structures put in place, and they have their own, like I said, social structure, hierarchy, rules. So there's a different way in terms of how you engage with an encampment versus an individual who may be sleeping rough or experiencing homelessness. There's a different way we go about that. To report, we have no known encampments in the district. We track that as with the DSAB. We can track the location, all of that stuff. And like I said, the work we did with ORCode gave us a proactive encampment response plan to support the municipalities if we see that problem coming to our area. Talked about housing loss prevention. Like I said, it's just a range of evidence-informed policies and interventions, just looking to stop housing loss before it occurs. Rapid resolution occurs within the first week of a shelter stay. The shorter, the better, or time on the street when an individual, couple, or family cannot be diverted. So we see this often with, in our area, we don't have a shelter per se, but we do have a voucher system with the OPP. We have a voucher system with the hospital as well, where if unhoused, unsheltered individuals needed accommodations, they can utilize a hotel and we will support it financially, but also too at that point we can engage with them, and it's short term. It's 1 night, 2 night, 3 nights. We're working to reunify them with family, get them to we're a very transient community, get them to their next place, their home community, get them to a shelter, that sort of stuff. Sometimes they stay, sometimes they go on our by names list, stuff like that. And diversion is the same concept, except we're intervening as they've lost their housing, but they're not in the shelter system and they're not sleeping outside. By names list, and we'll go over this later on too. The by names list is a real-time person-specific list that is used by service providers to track and coordinate services for individuals experiencing homelessness. It monitors all the inflow and outflow of homelessness, whether it's returns from housing, returns from inactive, new to homelessness, housed, and if we lose track of people too. As I mentioned, we want these shared definitions to support collaboration and coordination to address homelessness across the district. And these are all grounded in evidence and national best practices on homelessness response. This is a triage tool that our staff use in terms of, again, understanding where they fit on the continuum and if an individual is homeless, housed, or we're dealing with encampment response diversion or housing loss prevention. A lot of words. It's just basically an overview of everything I just said. So looking at a housing focused system of care and intersection points, again, this is a healthcare view in terms of ED and crisis, admissions to the hospital, discharge planning, and whatnot. As you guys know and probably have faced, housing insecurity can escalate risk and complexity, moving into discharge from hospitals. From a housing-focused viewpoint, the highest leverage point for prevention and/or diversion is at discharge planning. So the earlier we can be brought in, the and warm handoffs can happen. The better coordination of supports and services can be completed. And as I mentioned, the better collaboration, close case coordination of these supports increases the likelihood of success in housing stability. And what type of health supports drive stability? You guys all know this, I'm sure, but Ontario Health at Home, access to primary care, community mental health supports, and homemaking supports. Looking at the cost of homelessness and poverty, chronic homelessness is linked to shorter life expectancy, increased incidences of chronic disease and mental illness and addictions. Healthcare can often become the default system of care when housing and income supports are not available or not coordinated. Healthcare costs are often 6 times higher than those who are housed. Additionally, too, for people who have experienced chronic homelessness and have been housed, healthcare costs are still remain elevated to continue to stabilize physical and mental health. So that's why, again, it's better to keep the focus on prevention. And this information came from the Homeless Hub, from the cost of inaction, healthcare expenses associated with homelessness in Toronto, done by Lucy Jackson in 2024. Again, looking at the high public system costs with homelessness. As you guys would be aware, homelessness is associated with higher utilization of emergency and crisis-based services. Public systems that are impacted, the hospital, emergency departments, EMS, police and justice, shelters, social services, corrections, that sort of stuff. Without prevention and housing-focused supports, people continue to cycle through these systems without achieving any sort of real stability, continuing to cause strain to the system, as well as increased strain to the individual experiencing it. In 2025, a joint report completed by AMO, the Association of Municipalities of Ontario, OMSA, which is our Ontario Municipal Social Services Association, and NASDA, Northern Ontario Service Deliver Association, did a joint study conducted by Help Seeker, just to show the cost of and the pressure that municipalities and DSABs are under uh, when faced with homelessness. And this was updated as well for this year as well. An updated report was completed. And as well, NOSDA, which Parry Sound DSAB is a part of, did a joint study with CMHA Ontario around the cost of um, increased integrated health and housing supports and the impact on um, homelessness if those investments were made. So just wanted to give you a little bit of background before I get into numbers and all that stuff. So the Ontario scale, in 2025, we have 85,000 Ontarians who are known to be homeless. That was an 8% increase since 2024 and 50% increase since 2021. More than half of those individuals are chronically homeless. So they've been um, homeless for 6 months or more, or they've had repeated episodes of homelessness over an 18-month period. Also, there's been nearly 2,000 encampments reported across Ontario in 2025. And Indigenous people in Ontario are vastly overrepresented amongst those experiencing homelessness. So even though they're about 3% of the population, they account for 13.2% of homeless individuals province-wide and nearly 41% in northern communities. The study also did a projection of if we maintain the status quo, um, in terms of funding from the federal government, provincial government, uh, municipalities, that homelessness in Ontario is projected to double over 10 years and could approach 300,000 people in an economic downturn. And Northern Ontario is projected to more than double by 2035, pardon me. And if we saw an economic upturn, that number could be an increase by 10,000 people. If we remain steady, about 17,000 people, and in a downturn, close to 28,000 people. Again, just showing the rural and Northern Ontario pressure. Like I said, 30% of homeless grew in rural communities and 37% in Northern Ontario just in the last year. You're seeing that in the bigger centers such as like North Bay, Timmins, um, Sault Ste. Marie, Sudbury, um, for sure. Also in the smaller, more rural communities. And just to show again the context, Northern Ontario is about 5% of Ontario's population, but we make up 10% of known homelessness. So the reports talk about solutions as well, um, both in Ontario and for Northern Ontario. So for Ontario, the report recommends prioritizing long-term housing solutions over temporary emergency measures, paired again with prevention. That's been the theme of this. Again, moving away from shelters, but into building capital, affordable, deeply affordable, supportive housing for individuals. That investment would be about $11 billion over 10 years. And to deal with the encampment, to respond to the encampments, an additional $2 billion over 8 years to continue to provide support services such as outreach, transitional supportive, and community housing capacity. In Northern Ontario, it's recommended that housing solutions are most effective with integrated health and housing retention supports. Again, reducing the reliance on emergency services, shelters, and hospitals. And the cost estimate would be about $435 a year, targeted to integrate those supports. And again, reduce system pressures. The name of that report is 1.3 cents on every dollar would be the investment made in Northern Ontario. very cool things are happening, intersecting health and homelessness, social services. I'm not sure if people are aware of the social medicine project Dunhouse in Toronto through the University Health Network. Again, it provides healthcare and um, housing supports, led by Dr. Andrew Buzari. Again, another person, if you're interested, definitely check out his uh, information. He's definitely a big advocate for um, uh, homelessness for sure. Again, this is through the Addictions and Mental Health Ontario. This was shared with the sector leads in homelessness, just around making more cost-effective investments. You can see the breakdown of costs for cost per months of individuals um, uh, staying in a psychiatric hospital uh, versus the cost of supportive housing or transitional housing. It's a very stark contrast in what those costs are. So what's happening here? Want to get into, I've given you the Ontario context. I've given you the Northern Ontario context. What is happening on the ground here? So some background, as I mentioned, we engaged with our Mr. DeYoung's organization through the Canadian Alliance to End Homelessness um, to create housing loss prevention and encampment response strategy. Um, they spent time in our community. They engaged with some of our health partners. They engaged with some of our community partners, our staff, people with lived experience, and to get they wanted to get a clear picture of what the local context when it comes to homelessness in the district. This engagement helped define the strategy and has helped us define the work we do the work that we do, the scope and our approach to prevention in the district. From this, we've identified our goal with our board to end chronic homelessness in 2026. And this is a very realistic goal, I believe. And as I've mentioned several times, and this is my point, our goal is to make homelessness rare, brief, and non-recurring. So what are the local realities? So as I mentioned, our goal is to prevent housing loss by reducing the inflow into homelessness by intervening early. So if we see that people are struggling to pay their bills, providing support to access financial supports. If it's because of health-related issues, coordinating with our partners to ensure that the proper supports are put in place for that. Whatever it is, we're trying to put in, develop the strategies and plans to keep people in their homes as much as possible. So who do we see in this light? People who may be facing imminent housing loss, high acuity and complexity, repeated crisis use, also people who are discharge risks through the hospital. What are our core interventions? As I mentioned, we provide rear support, landlord engagement, mediation, rapid resolution and diversion, and housing-focused case conferencing with our health and community partners. Where might this intersect with the health system? We have many partnerships, which I'll touch on at the end of the presentation. I talked about it with the system of care, being a part of discharge planning for those people who may be at risk of homelessness or experiencing homelessness, coordinating at earlier stages, and also working to provide community follow-up supports to maintain housing stability. So again, here's the data. These are our prevention numbers that I wanted to highlight for you. We've been measuring since April 1st, 2025, because that's how our homelessness prevention funding is allocated. our cost per month and our total costs of homelessness prevention supports that we've issued to individuals and households. So you can see the cost as of last week. And again, a variety of different things that we pay for. About $300,000 has gone to that. We've looking at the slide I mentioned earlier around the costs of psychiatric hospitals, emergency admissions, all of that stuff. Very good investment and impact there. We have a range of priority groups that we measure as well. Indigenous Indigenous people are one, so we've supported 12. Transitioning from provincial institutions could mean correctional facilities, but it also could mean transitioning from the child welfare system, and as well as youth age 16 to 25 are priority groups for us. A breakdown in terms of the income source of the individuals that we've served. I went over the inadequacy of the social assistance rates earlier on in the presentation. Vast majority of people that we support are on OW and ODSP, but we also serve a significant number of seniors and low-income individuals as well. Again, focusing on prevention, 347 unique households served were at risk of homelessness. Again, going back to that prevention, keeping people in their homes. And then one sort of pain point I highlight again, and this came out in the work that Orco did with us in the strategy, and I mentioned it earlier. Affordability is a huge thing at the moment, and we're sitting at a precipice in terms of costs for people. We're seeing a lot of people who have come to us for the first time in the last year. So again, that shows that things are becoming more and more unaffordable for people. Again, just want to show people have multiple touch points, but the type of assistance that we provide in terms of case management or prevention activities, rapid resolution, 43 people we've been able to support from get out of the shelter system, the homelessness system quickly, as well as diversion, about 17 people. And the bottom chart shows just how many people we serve in a month. And again, I mentioned 404 unique households served, but we've served about 500 so far as of last week, just since April 1st last year. I mentioned the by names list earlier. And like I mentioned, it's a real-time tracking tool that measures the inflow and outflow of homelessness and supports the system of care towards finding coordinated housing solutions. And every municipality or DSAB is required to have a by names list in Ontario. So just for further context there. As part of our work with OrCode, we did a full review in 2025 to make sure one, the data was accurate, and two, it aligned with our objectives and our objective definitions, as well as our triaging algorithm. We continuously monitor the by names lists to make sure that the data is accurate and to maintain the real-time awareness of homelessness and the inflow and outflow of status of people. We use this data to prioritize clients that may be eligible for various supports and coordinate referrals. So this is our by names list. This is as of yesterday. So we have 4 active individuals who are homeless, who've given consent to be on the by names list. Since the by names list was implemented in September 2021, 390 people have been housed off of our by names list, which is about 70% of people, 70 to 71%. I mentioned earlier, there's inflow and outflow status with that. Um, the four people who are on our by names list um, are newly identified. So, which is good in a sense, because if we had a lot of people with the info status return from housing, it would show that the plans and the supports that we're making aren't um, aren't the right ones. We want people to maintain their housing and stay stable in their housing. So that's one of the key sort of performance indicators we look at. Um, Talked about the goal to end chronic homelessness. One of the four individuals on the by names list is deemed chronic homelessness, and 33% of all of the people that we've housed were experiencing chronic homelessness. So what does homelessness look like in the district? Part of what we capture with our by names list data collection is what their current sleeping arrangements are. So we don't have the visible homelessness as you would see in the streets of Toronto or Ottawa or Hamilton, um, that sort of stuff, but people couch surf. So we have people doing that. As I mentioned, we have some individuals who are, we don't have a shelter, so we utilize hotels for emergency shelter. We have a couple of individuals utilizing that right now. And we have one individual who is at a spree, our women's shelter, that we're supporting. We can also look at, I can gender, I can look at the barriers as well, what type of barriers individuals report, um, all of that stuff. So we get a really good snapshot in terms of the real-time picture of homelessness in the district. Um, what are some of the supports and services in place that we have? One of the things that we've started in the last 18 months or so has been our transitional units. So we have 6 units throughout the district, one in Powassan, 4 in South River, and 1 in Parry Sound. And the purpose of that is to provide short-term supportive housing to stabilize clients and bridge them to permanent housing. So these are individuals who are on our by names list that are experiencing homelessness and need a safe place to stay and are ready to engage with us. The individuals that we target for this are low and medium acuity. We don't have the resources in the district at this time for supportive housing to deal with people with more high acuity needs. And the approach is we try to provide individualized wraparound supports, so housing, system navigation, income supports, life skills training, and health and mental health linkages as well. Again, more data. We've had several people graduate from our program, find safe and stable housing. We were able to get qualitative data from them in terms of their experience in the program, their level of support, their confidence level moving into housing, their preparedness level moving into housing. And again, all the results were very strong. Individuals who have been housed at least 6 months remain housed. And we're nearing our next cohort who have that 6 month period. So again, measuring performance to see, if people are maintaining their momentum and progress. Again, just demographic information as well, age range, gender, that sort of stuff. Again, this work isn't done in a silo for us. We are very grateful to the West Parry Sound Health Center for the various partnerships that we have and the relationships that we have had. It definitely has helped us work to make homelessness rare, brief, and non-reoccurring. And I just want to highlight that as get to the end of my presentation. So we have a mental health and addiction social worker that provides support and enhanced system navigation for DSAB clients. She is fantastic. We have an MOU with community paramedicine. So our my staff, we call them integrated system navigators. They provide we don't have the supports and services to do outreach, housing case management, all of that stuff. We kind of do it all, as well as OW and all of that stuff. We work very closely with community paramedicine to um, work with vulnerable individuals, um, people who may be sleeping rough. We will utilize them for encampment response. Community paramedicine also supports our shelter, supports our community housing buildings through wellness clinics and whatnot. Fantastic relationship and partnership there. The MPLC clinics have supported our unattached clients through referrals and orphan clinics. We've also had a recent partnership with community support services to provide homemaker supports, helping low-income households and seniors stay in their homes. Through the pandemic, you guys will remember the hotel projects at the Midtown as well as Caswell's and Sunridge. We worked very closely with the healthcare system to support individuals in that program, including vaccine clinics, healthcare supports, that sort of stuff. As well, I'm also the co-chair of the Health and Social Services Network, so it gives us another chance to promote and enhance integration and partnership at that table. And the DSAB is a collaborative partner of the West Parry Sound OHT as well. So that's it for me. I'll leave it open to questions from there. Thank you very much.
Thank you very much, Jeff. We'll open the floor up if anyone wants to ask a question. You're more than welcome to unmute and ask.
Hi, it's Victoria Smith. Can you hear me?
Yes, we can.
Awesome. Jeff, thanks so much for your presentation and for all the hard work that you and your team have done. It's really incredible to see your work. I work in the emergency department, and my question is probably more of a specific one in terms of managing unhoused patients through the ED, and specifically how best to manage patients particularly after hours. And I guess I was sort of aware of the hotel vouchers and that OPP has them, but can you walk me through what that might look like in terms of accessing the vouchers or accessing your team and how to link them with your team after hours?
Absolutely. So we did have the partnership with the hospital and the emergency department to utilize the voucher system as well. So if you were experiencing people after hours that needed accommodation, emergency shelter, we would definitely can utilize that system. If it seems to have fallen off, we can connect and get that back on track. I know the hospital did have some funding at one point that they were using to provide that service. So, but I think that was limited, so it may have just fallen off. But we would definitely want to utilize the voucher system. And what it is, it basically is just giving approval to the hotel operators that the bill's going to get paid and what they need. So we've used it for, we use the OPPs, use them for hotels or food or transportation, that sort of stuff.
And further to that, is it a specific agreement with a specific hotel, or is it any in the region? And are there stipulations around substance use and that kind of thing?
In terms of substance use, no stipulations there. I think that would be with the local hotel. We can work with you to give you a sense of the hotels that work with us, so that we're all working from the same script, and we can go from there. But we would try and wrap around them fairly quickly so that, again, we want to uh, resolve the situation quickly so that they're not getting stuck into the hotels or the shelter system. We want to find out what housing focus supports are needed.
Perfect. And final question to that, does DSAB cover transportation like a taxi to the hotel from the hospital? Because hospital funding, as you may be aware, is being slashed by 3 million, and the hospital is no longer covering taxis for patients' transportation.
Potentially, we could through the voucher system, yes.
Okay, thanks. Maybe we can connect to get some more details. Is your email in the chat, or
Oh, I can
do you
put it
mind
in
to?
the chat. Yeah, for
Amazing.
sure.
Yeah,
Yeah,
awesome. Thanks.
yeah.
And I don't know if you see there's a question in the chat for you as well, Jeff.
Yes.
How do people who are newly homeless connect with DSAB?
So the best bet, what we tell everybody, is to call our intake line. So, and I'll put the number into the chat. But if you call DSAB extension 500, and then our intake team can triage from there. So that's the easiest, best way to go about it. So I put my thing in the chat, my email address in the chat. I would be happy to talk to individual teams at the health center too, or have members of my team come and speak too. I know this is a bit more high level, so we're definitely again, we want to be able to work collaboratively. We want to be able to speak the same language, working to get the best outcomes.
I'm not seeing anyone else unmute. I guess, just reach out to you directly if they want to connect with you further. And
Yes, absolutely. Yeah.
okay, perfect. Excellent. So one more comment. Appreciate the information today. Thank you.
Thank you for having me.
And that's it. No, thank you so much for coming and sharing your knowledge. Oh, there's another question. Can you see that, or do you want me to read it off?
No, I can see it. In terms of early intervention as a primary care. You can definitely, if you have the person's consent, you could definitely refer them over to us. Um, Absolutely. We don't want to have increased barriers. What cases are considered high acuity versus low or medium acuity? So, versus what we're looking at in our transitional units at the moment, um, medical issues, mobility issues, those types of things, especially with the ones in South River. We have stairs and stuff like that, so we want to be mindful of that. Um, we want to be mindful too of where their mental health is at, or where they're at with addiction as well. It's not to say that they can't be in there, but there needs to be a level of support just because um, it's not, we're not staffed, we don't staff it 24/7. It's just around safety for everybody in the buildings that they're in or in the duplex that we have in South River. So hope that helps. Thanks,
Okay.
Judy.
I'm not seeing any last minute questions coming in. So thank you so much for coming and sharing your hard work with our team today. It's certainly been an eye opener for me. I knew about DSAB, but I didn't know a lot about your services. So this was very helpful for myself, and I'm sure most of our team. So thank you very much. And just for everybody else, our next set of rounds by Zoom will be April 23rd, and it will be with Dr. Zara Kassam, who is an oncologist. We're just working out the details on her talk. So thank you. And we'll see everyone April 23rd.